Happy morning to everyone. I'm sure the winter in Delhi is quite significant. Even in the southern part of India, Coimbatore, where I live in, the winter is pretty chill this year. I'm sure it will be much worse in Delhi. And I'm extremely happy that in spite of this winter, you continue to do inspiring academic sessions in the early hours of the day between 6:30 and 7:30. Today, I will be sharing with all of you certain thoughts on the newer facial plane blocks and its implications on patient outcome after onco surgeries. I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore. But before that, I would extend my very sincere thanks to the Department of Onco Anesthesia and Palliative Medicine at the All India Institute of Medical Science, New Delhi. My special thanks are due to the Chief, Dr. Sushma Bhatnagar, whom I've known since the national meeting in Coimbatore way back in 2002, and the young Turk, Dr. Rakesh Garg, and the entire Department of Anesthesia at AIIMS, New Delhi, Onco Anesthesia Division for this excellent academic initiative. I welcome you all to the Ganga Institute, the Ganga Hospital. It's a tertiary care referral center, and we have a new block which is added, which has made this hospital into a 650-bedded hospital with roughly about 150 surgeries per day. We also do a lot of tumor-related surgeries, but most of them are related to orthopedic and spine practice. And we also treat some of the patients who come with chronic pain, but specifically related to this specialization. I'm sure that you will all agree with me, the single most important symptom for which a patient comes to a hospital across the globe is pain. And I think we, the anesthesiologists, have been empowered with several methods in which we can alleviate pain. And hence, if we do the job appropriately, we truly become the angels to the patients, because pain relief is paramount in the patients who come to us. And nevertheless, it's very, very important that though we are called angels, we need to introspect and ask a question to ourselves whether we do enough, whether we make the perioperative period extremely pain-free for the patient. And today I'm going to focus on interfacial plane blocks and especially the chest. The last 2 decades, we have seen the resurgence of regional anesthesia. And there has been extensive work in the cadaveric labs where the anatomist along with the regional anesthesia enthusiast have found out several new blocks which will help to enhance the multimodal pain relief in the perioperative period. And today I'm going to take a prototype. If you go through the literature, you will understand that CA breast and the post surgery, the significant pain that they experience have become one of the most important concern to all the physicians who work in the perioperative period with the onco patients. So I will take this as an example in discussing the interfacial plane blocks today, especially to the perioperative analgesia in breast surgery. This is an article which was published in the Regional Anesthesia and Pain Medicine, an original article on the impact of regional anesthesia on recurrence, metastasis, and immune response in breast cancer surgery. And we all know that one of the gold standard block which was used by regional anesthetists for decades has been the paravertebral blocks. And this particular article also reviews on the paravertebral block. Article says that paravertebral block could be associated with improvements in long-term survival after breast cancer surgery by modulating the inflammatory and immune response associated with the surgical trauma. It also reduces the opioid consumption and also the general anesthetic consumption, and it promotes death of cancer cells by direct effect of local anesthetics. These are the several proposed interesting theories which have come into being in the last few years. But this particular article concluded that there is no data to support or refute the use of paravertebral block for reduction of cancer recurrence or improvement in cancer-related survival. However, paravertebral block use is associated with lower levels of inflammation and a better immune response in comparison with general anesthesia and opioid-based analgesia. So there seems to be a definitive advantage of using regional anesthesia over general anesthesia, or even if you use general anesthesia, to incorporate regional anesthesia along with this in breast cancer surgeries. This is another very nice article. Are cure rates for breast cancer improved by local and regional anesthesia? So in this article, though it was done in 2006, this was the first article which concluded that paravertebral block as an adjunct to general anesthesia was associated with a remarkable four-fold reduction in breast cancer recurrence compared with GA. The follow-up studies from these investigators are very interesting. It demonstrated that patients' pro-inflammatory cytokine profiles were more favorable for cancer immune competence in patients receiving regional anesthesia, presumably because of attenuation of the neuroendocrine stress response to surgery. Many studies of cell-mediated immunity, cell signaling pathways affecting immunity, and other molecular mediators have now been published, citing the potential advantage of regional anesthesia over general anesthesia for host tumor competence. So this is another article, a review article, which says neural blockade for persistent pain after breast cancer surgery. This is something very important. Henrik Kellett proposed this study, and this study clearly indicates that the number of patients post-breast surgery, cancer surgery, coming for severe persistent pain. In some centers, they report the incidence of persistent pain after breast surgery to as close as 1 in 2. And it is again imperative that we learn the regional anesthesia blocks because of these factors. So today I'm going to focus on interfacial plane blocks. Have they improved the perioperative period? Answer is definitely yes. It produces a better perioperative analgesia, and all the current studies indicate reduced pain scores in the first 24 hours. It also reduced the opioid consumption in the first 12 hours. Apart from this, patient comfort levels increased because of less of nausea and vomiting, less sedation because of the requirement of opioids was less, and it was possible to extubate the patients in extensive surgeries when they are on ventilator much earlier. And it also resulted in a shorter stay in the post-anesthesia care unit and in general, the overall stay in the hospital. And the most important has been the less incidence of chronic pain. So when acute pain is addressed appropriately in the perioperative period, the chances of patients developing chronic pain syndromes becomes extremely less. Now, we saw in the previous articles, the gold standard in breast surgeries was to use either a thoracic epidural analgesia or a paravertebral block. Now, we are moving into the newer block or the interfacial plane block, which I'm going to describe to you and discuss with you. And how is that this new interfacial plane blocks better than the traditional thoracic paravertebral block? Number one is easy to perform. Number two, it's a low risk profile, very simple and safe to perform. And You can see one and do one and master one. So it's as simple as that. And more importantly, there is no sympathetic blockade that is associated with interfacial plane blocks compared to your thoracic paravertebral block. There are no major vessels when you do the block, so the risk of bleeding is very less. And since the tissue injury is very less when you perform the block, it could be performed in both awake and an anesthetized patient. And the real-time visualization of the drug spread and the way you do it with an ultrasound has made a world of difference in getting the interfacial blocks successfully done in our patients. Now, we will go into the perioperative breast analgesia. This is an excellent article which I would ask all the postgraduate students to go through. The perioperative breast analgesia, a qualitative review of anatomy and regional technique, is one of the best published data as far as this particular specialization is concerned, published in 2017. Now, we all know that breast cancer statistics are alarming, and in spite of our progress in early diagnosis, even today, breast cancer surgeries pose a great challenge to us because of its incidence. And when we talk about interfacial plane blocks, it becomes pertinent to know which one to choose. And the decision to choose the block of choice depends upon the type of surgery. And I know that you're all experts in this. I'm not an expert, but I just would wanted to focus that the surgery and the tissue destruction depends upon the type of procedure. It could just be a lump excision, or it could be a wide excision, or it could be a quadrantectomy, or it can be a total mastectomy or a modified radical mastectomy. So the breast surgeries differ in terms of tissue destruction, differ in terms of the nerves that are involved which carry the pain from them. So to understand that better, in the next few slides, I will show you the innovation. But one thing which is very certain is post-mastectomy pain syndrome is very, very crucial and important. And this can be made simple or can be made non-existent by using appropriate blocks, for which you should know the innovation of the chest wall. So the breast innovation, you need to focus initially on all the nerves that are involved in supplying the breast. The supraclavicular nerves, which arise from the brachial plexus, gives the cutaneous distribution to the superior breast. The cutaneous distribution of the lateral part of the breast is supplied by the lateral cutaneous branches of the intercostal nerve. And the medial part of the cutaneous part of the breast is supplied by the anterior cutaneous branches of the intercostal nerve, especially from T2 to T5, with contributions from T6 and T1 occasionally. So the cutaneous distribution of the breast depends upon three primary nerves: the supraclavicular nerves, the superior breast, the lateral aspect of the breast by the lateral cutaneous branches of the intercostal, and the medial side of the cutaneous part of the breast is by the anterior cutaneous branches of the intercostal nerves. The next nerves that we need to know are the lateral pectoral and the medial pectoral nerve. These two nerves supplies the pectoralis major and pectoralis minor and form an inherent component of breast innervation. Because these muscles are either infiltrated by the tumor cells or dissected during the surgical procedure, and hence blocking these nerves prior to the tissue destruction results in decreased in persistent pain in the postoperative period. A nerve of great significance is intercostobrachial nerve, which has its root value from T2. And in the post-surgical pain syndrome, one of the commonest implication has been due to the involvement of the intercostobrachial nerve during breast surgery, especially when there has been an axillary dissection or an axillary biopsy has been taken. This nerve gets injured and it produces persistent pain. Two other nerves of clinical significance that we need to know are the long thoracic nerve and the thoracodorsal nerve. And these again may be involved during the breast surgery, which could result in persistent pain post-surgery. So this innovation becomes very crucial for us to understand the interfacial plane block. This is just to show you that the T2 to T5 intercostal nerve. So this is the intercostal nerve. It divides into, this is the dorsal ramus and this is the ventral ramus. And the ventral ramus at the angle of the rib gives the lateral cutaneous branch, and then it goes up, and then you see the nerve pierces the intercostal muscle to supply the anterior cutaneous, this anterior cutaneous nerve, and which supplies the medial part of the breast. So in the cutaneous distribution, if you see, this lateral cutaneous nerve and the anterior cutaneous nerve form a significant contribution in pain. And this is just to summarize what we discussed so far. The cutaneous distribution, to recall, supraclavicular nerve, or we call it a superficial cervical plexus, which comes from the brachial plexus. Then you have from T1 to T7, the intercostal nerve through its lateral cutaneous branch, both the anterior and posterior division of the lateral cutaneous branch. Then the medial cutaneous branch from T1 to T6, it's got a medial division and a lateral division, and the intercostobrachial nerve. I'm sure that I've made things very clear. And next we go to the innervation of the muscles of the chest wall. From the brachial plexus, we have lateral pectoral nerve C5 and C7, medial pectoral nerve C7 to T1, the long thoracic nerve C5 to C7, and thoracodorsal nerve C6 to C8. I'm speaking about the innervation because I wanted to make sure that we are extremely clear on which nerve that we will block based upon which procedure that they are doing. You know that there is a current thinking prospect, procedure specific analgesia, and for that it becomes important that we have a very strong foundation on what we discussed. And at this point, again, I would wanted to let you know this particular innervation is important because the myofascial pain is one of the significant pain post-surgery, and this happens because of disruption, stretching, or spasm of the pectoral muscle or the fascia. And hence, it's important to block these nerves. And it also is important to know about the neuropathic pain post-surgical, either because of the traction during the surgery or due to the irradiation or due to the direct neural injury. So it's very important to know these factors. So now today I'm going to focus on erector spinae plane block, PEX1, PEX2, serratus plane block, pecto-intercostal plane block, and transverse thoracic plane block. So this is a kind of a pictorial representation. I think I will go into each block separately. The transducers that you use when you use an ultrasound, all the blocks are performed with ultrasound, and generally we use a high frequency linear probe with 6 to 13 megahertz. And occasionally, if the patient is very obese and you want to increase the field of vision, you may decide to go on a low frequency probe. But most of the time for chest wall blocks, I prefer using a high frequency linear probe. And this just to quickly recap what you do in a paravertebral block. See the one where this is the paravertebral space, and you flood this paravertebral space with local anesthetic solution, and you just block the intercostals as they come out. And also remember that the sympathetic chain also gets blocked in a paravertebral block. So a paravertebral block is done with the paramedian approach, and this is exactly what you do in a paravertebral block. So you have the trapezius, rhomboidus, erector spinae. You have both the transverse process. And here is the superior costotransverse ligament, and this is the pleura. So when you do a thoracic paravertebral block, you deposit the drug below the superior costotransverse ligament, and the best important sign that you get is the pleura moves down, and there is an anechoic area created by the local anesthetic spread. So paravertebral block was the gold standard. And this is a sonoanatomy that here you see the skin, the subcutaneous tissue, the trapezius muscle, the rhomboides, the erector spinae, and this is the pleura. And that's the transverse process, the acoustic shadow that you see. And these are the two transverse process, and this is the ligament, superior costotransverse ligament. So this is the paravertebral space where you inject the drug. So we can also do it in a transverse approach. Now, the complications which related to the thoracic paravertebral block was, number one, it needs proficiency. So block failure was very common. And since it's very close to the neuraxial region, there can be inadvertent epidural or intrathecal injection, epidural spread and hypotension. Since the pleura is close by, you can have a pneumothorax, an intrapleural injection. And you can also, because you need a larger volume, can result in local anesthetic toxicity. So now, this new interfacial plane block called the erector spinae plane block, much simpler. So what do you do here? So you see, like in the paravertebral block, you gave the drug here, but now you just wait for it to come out and you inject the drug between the transverse process and the erector spinae muscle. And the simplest of the simple block that you can ever do. And I think even the first year postgraduate should be capable of doing this, and he should be taught this. And this is the anatomy of the, this is the transverse process that you see. And here you see the costotransverse junction. So all that you would wanted to do is skin, subcutaneous tissue, and the muscles, rhomboides, trapezius, and erector spinae. This is the transverse process. That's the needle coming in. You deposit the drug between the ESM, the erector spinae muscle, and the transverse process. So you hit the needle hit the periosteum of the transverse process and just inject the drug. And when you do a breast surgery, you can keep it at the level, you can do it preemptively prior to the surgery, and you can inject this at the level of T4 or T5. And when we use a volume of about 12 to 15 ml with dexamethasone, you can see the drug spreading completely 3 to 4 segments above and 3 to 4 segments below. So this is a pictorial representation. The patients can be done in a sitting position or a lateral position. It shows the using the high frequency transducer, and this is exactly the place where you will deposit the drug. So that's the skin, subcutaneous tissue, trapezius, rhomboid, erector spinae, and this is the sonoanatomy in a bigger version. That's the trapezius, rhomboids, erector spinae, transverse process, and you hit the transverse process here and deposit the drug, and you will see the anechoic spread. So as I said, you can give about 10 to 12 ml and initially, and this could be followed by, you can use catheters here, and you can continue it with about 6 to 10 ml per hour. What are the complications of this? Sometimes when you are not exactly positioned the drug in this space, there should be a block failure. The whole drug can go into the intramuscular area, inside the erector spinae. Sometimes, very rarely, when the needle goes further inside, it can produce a pneumothorax. and local anesthetic toxicity. That's why the volume that you give is, you can considerably reduce to about 12 to 15 ml now. And very rarely you see epidural spread and hypotension. So this is just to show that sometimes what happens that you place the drug inside the muscle mass and it's not between the muscle and the transverse process. This you need to avoid. So that's about the erector spinae, excellent quality of analgesia, and the intercostal nerves T2 to T7 can be completely blocked by giving an erector spinae block. And this is a block which is considered to be one of the easiest block, can be done effectively with the use of an ultrasound, and it becomes the bread and butter block for every young anesthesiologist who is graduating now. Now we move on to the erector spinae was predominantly to look after the innervation of the breast, which was coming from the intercostals. Now we will move on to the interfacial blocks, which have been performed in relationship to the nerves that arise from the brachial plexus. And we have two blocks, the PEC1 block and the PEC2 block. In the PEC1 block, you deposit your drug between the pectoralis major and pectoralis minor. This is how the probe position is, a high frequency linear probe, and the marker can be cephalid, and this is how you position the probe, and you will see the muscle mass, and it's very, very easy to see the pectoralis major muscle here. So this is the pectoralis major, and this is the fascia between the major and the minor. And this is at the level of the second rib. You identify the ribs because you see the acoustic shadow, and down here is the pleura, and here is the third rib. So now when you deposit the drug in this interfacial plane between PEC major and PEC minor, it's called the PEC1 block. So patient in supine position, done at the level of rib 2 in the mid-clavicular line. High frequency linear probe. You can use a 22 or a 23 gauge 5 centimeter short bevel needle. The direction could be cranial to caudal, or you can even go out of plane technique. Local anesthetic you use is a 0.25% bupivacaine or 0.375% ropivacaine. When you do a single dose, you do with 10 to 15 ml. And what do you block? You block the lateral pectoral and the medial pectoral nerve. And next we go to the PEC2 block. So the PEC2 block is the next interfacial plane block, which is of great relevance. And here you deposit the drug. The sonoanatomy is just similar, but the only difference that you see between PEC1 and PEC2 is that you have moved the probe slightly caudal, and you will position, you will see you count the ribs, and this will be done at the level of the fourth rib. So you see the PEC major here, you see the PEC minor, and most importantly, you see the third muscle that is coming inside, that's the serratus anterior muscle. And here is the pleura. So now here we do two blocks. One here between PEC major and minor, and the second one is between PEC minor and the serratus anterior. 2 injections are done in this block, and this is a summary of what you do with the PEC2 block. Supine position in the fourth rib level, anterior axillary line, high frequency linear probe, and the drug is similar to the PEC1. And in the first block, in the first injection that you make, you give 10 ml of 0.25% bupivacaine, and the second injection you give about 10 to 20 ml of your 0.25% bupivacaine. So the nerves that are blocked here are lateral pectoral nerve, the medial pectoral nerve, the T2 to T6 intercostal, especially the anterior division of the lateral cutaneous branches of the intercostal, and the long thoracic nerve and the thoracodorsal nerve. Next, we move on to the serratus plane block. This is another block which has come into vogue recently, and this is the probe position. You have moved the probe further down to the level of the fifth rib, and here you will be seeing the latissimus dorsi, and the serratus anterior. I'm going to show you the sono anatomy. So that's the fifth rib. This is, you see the serratus anterior coming and getting inserted, and above that, this is the latissimus dorsi. And majority of the time, you see the pulsation of the thoracodorsal artery. So the block can be performed in two ways. It's called the serratus anterior plane block, superficial and deep. The one which you place between the rib and the serratus anterior muscle. You come and hit the fifth rib and you deposit the drug here. You see an anechoic spread here. And the next one is you place the drug between the latissimus dorsi and the serratus anterior in this fascial plane. So this is the serratus anterior block. So to summarize this block, done in supine position in the fourth and the fifth rib in the mid-axillary line. It's a transverse orientation of the high frequency linear probe. You use a 22 or a 23 gauge 5 centimeter short bevel needle, and the drug used is 0.25% bupivacaine. So the volume that you use, either you do a superficial block or whether you do a deep block, you use about 20 ml of the drug. What does this the SAP block, what are the nerves that are blocked? T2 to T9 intercostal, the anterior division of the lateral cutaneous branch of the intercostal, and also it blocks the long thoracic nerve and the thoracodorsal nerve. So this is how the drug is placed. The superficial one is between latissimus dorsi and the serratus anterior, and the deeper one is between serratus anterior and the rib. So we have anterior cutaneous branches. So we dealt with most of the other nerves except the anterior cutaneous branches of the intercostal nerves. And this is to just show what happens to the anterior cutaneous branches lateral to the sternum. And two blocks have been described. One is pecto-intercostal plane block. This is again a very, very simple block to do. And the local anesthetic is infiltrated between pec major and the internal intercostal muscle between the ribs, done anteriorly. So this is how you place it in the parasternal region, cephalad to caudal. And this is the sonoanatomy you see. So that's the rib, third rib. And skin, subcutaneous tissue, pectoralis major, intercostal muscle. So in this fascial plane, you place the drug. And you use a high frequency linear probe, and you decide to give 0.25% bupivacaine. A single dose of 15 to 20 ml of the drug is given. This blocks the anterior cutaneous branches of the intercostal from T2 to T6. The next block which has been described is the transversus thoracis muscle plane block. This is another new interfacial plane block. The sonoanatomy is similar to the previous one, but the drug is deposited between the intercostal muscle and the transversus thoracis muscle. So this is the sonoanatomy that you see here. So here is the skin, subcutaneous tissue, pectoralis major, the intercostal muscle, and the thin, slim transversus thoracic muscle, and that's the pleura. And you place the drug between the intercostal and the transversus thoracis muscle. And this particular block results in a good blockade of the intercostal nerves from T2 to T6, especially the anterior cutaneous branches, and the volume you need is about 15 to 20 ml. And similar to the previous block, it's a parasternal block at the level of rib 3 and 4. And it is these are the blocks which have been used for all sternotomies, and the patients undergoing open heart surgeries. A fast tracking has been done because of using these simple parasternal blocks. So in the last 35 minutes, I just gave a bird's eye view of certain very, very simple interfacial plane blocks, which could be done along with general anesthesia in all the patients who are undergoing breast cancer surgeries to make sure that they get excellent perioperative pain relief. And also this would result in decreased use of general anesthetics, decreased use of opioids, decreased in post-surgical pain. So I look forward for a day when there would be a publication from our country by incorporating these interfacial plain blocks quite extensively in all the patients who are undergoing surgery preemptively before the incision is made. That would result in decrease in the number of patients presenting in the OPD again with chronic persistent pain. If we do this, we have done enormous justice for us being given the opportunity to work as an anesthesiologist. I take this opportunity to sincerely thank Dr. Sushma Bhatnagar, Dr. Rakesh Garg, and the entire Department of Onco Anesthesia at All India Institute of Medical Science for giving me an opportunity to share with you some of the thoughts on the newer interfacial plain blocks and its effect in the perioperative period and possible outcome in cancer patients. Thank you so much and have a lovely day.